Hi there, I'm Dr. Wu, a neurosurgeon who specializes in movement disorders. Today, I wanted to show you that deep brain stimulation, or DBS, isn't some brand new or experimental treatment. It's actually the result of a century of surgical work to treat movement disorders. And the history behind it is really fascinating, in my opinion. Back in the early 1900s, surgeons were already trying different procedures to help patients with tremor or Parkinson's disease. These early surgeries were very invasive, opening the skull and removing or disconnecting parts of the brain that controlled movement. Ablation, or burning and destroying part of the brain, was a main tool used to stop symptoms. And the idea was simple. If you didn't move at all, you couldn't have abnormal movements. But of course, this came with serious risks like hemiplegia, which is paralysis on one side of the body. A major innovation came in 1908 with the invention of the stereotactic frame. This here is a modern version, but it works on the same principle of stereotaxy. What it did was give surgeons much more accuracy when targeting deep brain structures. Let's fast forward to 1952, and we get one of the most interesting moments in this story. A neurosurgeon named Dr. Irving Cooper was doing a pedunculotomy, a procedure that involves cutting part of the brainstem to stop movement altogether. But during the procedure, he actually damaged the artery. He closed it off to stop the bleeding and aborted the surgery. Now, because the procedure was incomplete, Dr. Cooper didn't expect much change. But when the patient woke up, the tremor was gone, and he could still move both his arms and legs. It turns out that the artery he closed off was the anterior choroidal artery, which supplies blood to deep parts of the brain called the basal ganglia. These are the areas that help regulate movement, and that accident led Dr. Cooper to explore these deep brain regions more intentionally, helping to shape what I call the early stereotactic era of the 1950s and 1960s. And none of that would have been possible without the earlier invention of the stereotactic frame. Then, in 1968, a medication called Levodopa came along. It worked so well that it put a stop to most surgeries. I call this the latent period of surgery for movement disorders, a time when medication took center stage. But in the 1980s, surgery made a big comeback. This is especially thanks to Professor Alim-Louis Benabid. He and others had been experimenting with stimulation, using electrical signals to change brain activity. Professor Benabid found that stimulation had similar effects to ablation, but with one major advantage. It was temporary and reversible. And here's what's really smart about what he did. He had patients with tremor on both sides, but he knew that doing an ablation on both sides carried serious risks. So instead, he treated one side with ablation and the other with deep brain stimulation. And it worked. He published his findings in this paper, and that was a real turning point. DBS offered a safer, adjustable, and reversible alternative. The risk-benefit ratio clearly shifted in favor of patients. And for that reason, Professor Benabid is often considered the father of modern deep brain stimulation. Based on his work, DBS was approved in 1997 for essential tremor and in 2002 for Parkinson's disease. Since then, over 200,000 people worldwide have had the procedure, and neurosurgeons perform more than 12,000 new cases every year, and that number continues to grow. Now, here's something that I find interesting. For decades, we moved away from ablation in favor of deep brain stimulation. But today, with new technologies like focused ultrasound, ablation is making a comeback. It's important to keep in mind that focused ultrasound still creates an irreversible lesion, just like the older surgical methods. The difference? We can now do it without any incisions, just using sound waves to precisely target those deep brain areas. It's an old technique with a modern twist. And let's be honest, ultrasound sounds a lot less intimidating than burning a hole in your brain. So hopefully what I've shown you is that DBS is not new at all. It is the result of decades of innovation, learning, and surgical progress in the treatment of movement disorders. In the next videos, I plan to go over the benefits of DBS and who might be a good candidate for the procedure. Thanks for watching, and I'll see you next time.